Is that showing for you guys? Am I sharing my screen?
We're seeing you. I think you're sharing probably the wrong screen. If you have two screens, you need to change it.
I only have one screen, so let me awkwardly break through this.
You might need to make her co-host, Cheryl. Make Sarah co-host.
Okay. Let's see.
So the best part of the recording will be this part where we're all
Exactly.
waiting on our
Great.
technology.
Let's see what happens if I do this.
There you go.
Yeah, okay.
Okay.
I think I got it, Cheryl.
Thank you.
Sorry, we do so much of ours in a different platform, so then I just get a little confused. Hi, everyone. I just want to check and see, Darren and Julia, are you on yet? I know we're starting a little bit early.
Yeah, I'm on, Sarah. This is Darren. So thanks for having us, everybody.
And I'm here too, Sarah. This is
good.
Julia.
Good. Okay. Thanks. I just wanted to see who all we had. Well, everyone, thank you so much for this invitation. I know the three of us are really excited to be able to have the opportunity to talk to you all on this hot topic that can be a little overwhelming and confusing and perhaps sometimes even frustrating, definitely for families who are working with kids who have Arfid. And I think it can be challenging for those of us who are providers as well. So as Cheryl mentioned, yes, I am Sarah Sahl. When I was at WIC, I was Sarah Fife, and it was so exciting for me to see Sinaida and hear her voice because I worked with her 11 years ago at WIC in Washington County. And since that time, I've been part of the feeding clinic up at the CDRC, really specializing on working with kids with feeding challenges and developmental disabilities. And I'm really fortunate to be a part of a very talented multidisciplinary team, which includes several people, but today, I have the pleasure of presenting alongside my counterparts here, Darren Janzen, who's a clinical psychologist who does a lot of work with behavior, particularly with kind of the parent-child dynamics with feeding, and Julia Farrell, who is an occupational therapist, and you might see those extra letters at the end of her name there. She is an IBCLC. We got the pleasure of meeting her when she came to Oregon to obtain her IBCLC certification and started working with us as flex staff. And I worked pretty darn hard to get her to join our team because she's amazing. So I'm happy that we're going to be able to get to sort of present this from a multi-pronged approach, because I think of this as something that just a dietitian alone is not going to be able to fix, but we can maybe help to avoid some major pitfalls. And I wanted to just give a little bit of credit to, at the beginning, we actually gave a similar presentation to this to a group of pediatricians recently. And the beginning part of the slide, or the presentation that goes over all the diagnostics, a lot of that work was done by the gastroenterologist on our team, Dr. Sylvia Doan. So I need to give a shout out to her and give her some credit, but she was not able to join today. So I'm going to start with that. I'm trying. I know that we're recording. I'm guessing there will be questions that come up during the presentation. Feel free to enter things into the chat, and we should have time. I'm certain we'll have time for question and answer at the end. So either jot them down to ask at the end, or like I said, enter them in the chat, and we'll be sure to try and address those. So the objectives of our talk today are understanding the diagnostic criteria for Arfid, considerations for community dietitians who are caring for kids who have Arfid, what are red flags, when might we suggest a referral to therapy, or when might we be thinking like, there just might be something medically going on that hasn't been identified yet, and then what's our role? And then we're going to have at least one case study to go over at the end. Oh. Your screen must look like my screen, right? So I'm going to move us. I hope that's okay. So maybe I want that a little bit bigger. Okay. So Arfid is part of we call this the DSM-5. So it is a diagnostic code that has very specific criteria. It's used in very specific situations. And I think it's important for us to kind of lay this foundation, because I don't know about you guys, but there are definitely times when families will come in and talk about things, and we don't know for sure if that was a medical diagnosis, if that was something that they had come up with on their own, or if the diagnostic criteria had been met. So in 2013, avoidant restrictive food intake disorder became an official diagnosis within the American Psychiatric Association DSM-5. And before that, there had really been kind of a gap in what you could call kids, what you could diagnose them with if they were having a feeding disturbance. So this is the DSM-4, the earlier version. What they had was really, a feeding disorder of infancy or early childhood. And there are some specific criteria, but, it's saying that this is manifested by persistent failure to eat adequately. There's usually not adequate weight gain or significant loss of weight, and that the duration would be for over a month. As with the other conditions we're going to talk about today, that disturbance in eating isn't due to a medical condition. It seems to be separate or above and beyond whatever that medical condition may be causing them discomfort. That disturbance exceeds the discomfort. It's not better accounted for by another mental health disorder or a lack of available food. And with this earlier diagnosis, it was only for kids less than 6 years of age. So in 2013, this new code hit the ground, the avoidant restrictive food intake disorder, and you'll see some similarities here, but it's much more specific. So it's an eating or feeding disturbance that's manifested by persistent failure to meet appropriate nutritional needs associated with one or more of these following things: either weight loss or unmet growth expectations, nutritional deficiency, which could be micronutrient, dependent on nutritional supplements, marked interference with psychosocial functioning. So for example, I just got off an appointment with a family where the mom quit her job so that she could stay home and feed her child. And I'm going to say that would be an interference with psychosocial functioning. And exclusionary criteria, so I think this is important, and we'll hit on this later on in the talk, is that this is not a food insecurity issue. These are not kids who aren't eating because they are part of a culture that practices fasting. It's not that there's not food available. It's a restriction. It's not related to body image or weight concerns, so it doesn't have that body dysmorphism that's associated with kind of those traditional eating disorders that we think of with anorexia nervosa or bulimia. And again, it's not better explained by a medical condition. So if someone has untreated celiac, undiagnosed and untreated celiac disease, they may feel awful and not want to eat because it hurts. So this is not that. These people may have celiac disease, but the restriction goes above and beyond what we might consider to be normal for whatever their diagnosis is. And then this is a different diagnosis. So Arfid is part of, it's a mental health diagnosis, and pediatric feeding disorder is a medical diagnosis. So it is a disturbance of oral intake of nutrients that are inappropriate for age. Greater than 2 weeks is the duration, and it has to be associated with one or more of the following. So it has to have either a medical component, a nutritional dysfunction, feeding skill dysfunction, and or psychosocial dysfunction. So I'm just going to come back up here and say, medically there may be cardiorespiratory problems that are affecting the child's endurance and ability to eat. They may have challenges with the aspiration complications. They may have a GI process, food allergy, something like that. From our nutritional standpoint, there may be specific deficiencies. That may be that they're using supplements to avoid deficiencies or to maintain an appropriate weight. For skill, they may need modifications in their texture and their position or equipment, or modified feeding strategies. And I think it's important that when this diagnostic criteria was created, they were really specific that they wanted it to be a feeding skill not appropriate for age. We know that feeding skill tends to mimic developmental level and developmental skill. And for this diagnostic criteria to be met, they really did want it to be age and not skill, because they felt like there were medical needs and additional attention that should be provided to these families if they were not eating at an age-appropriate level. And then psychosocial dysfunction is an active avoidance or passive avoidance by the child, inappropriate caregiver management of the feeding process, or disrupted caregiver-child relationship. And we'll talk more about these things. And then again, it's absence of that cognitive process that's consistent with eating disorders and not due to a lack of food or associated with cultural norms. So kind of as I mentioned previously, the pediatric feeding disorder does use the framework for the World Health Organization International Classification of Functioning of Disability and Health. So this is acknowledging that this is more than a disease state. It's actually a disability that impacts various aspects of life. And it unifies these, it's really kind of what we're saying with Arfid too, unifies the medical, nutritional, feeding skill, and or psychosocial concern that are part of the feeding disorder. So often only one of those may be addressed and you're kind of missing the bigger picture and not able to get to the root of the problem. So kind of the differentiation between these two diagnoses, which are quite similar, both result in disordered eating. With Arfid, there's definitely a restriction and an avoidance of food. With pediatric feeding disorder, you may see that, you might not. It's common for poor appetite, really with both, but specifically in Arfid. Malnutrition is common in Arfid unless these are kids who are on supplements. Traumatic or chronic experience may be possible that's led to or resulted in the food refusal. There are often comorbidities, including anxiety and mental health disorders in Arfid. So I think that's why this does fall more in that mental health realm. We often see anxiety alongside Arfid. And down at the bottom, the pediatric feeding disorder is framed as a disability, whereas Arfid is not. So how does this happen? You know, we see these kids in our appointments and they're just eating a tiny handful of food. So how do we get there? And often there are medical problems that may be kind of the initial trigger. You know, I appreciate people who stop and say, you know, someone will say, oh, you know, it's a behavioral feeding problem. But I think it's important for us to always look and say, but what caused the behavior? What led that child to begin to refuse eating in the first place or to be fearful of eating? So that medical problem, there's a dysfunctional feeding relationship or other interruption that can promote a conditioned food aversion. So, you know, if a child starts to refuse food or combat the spoon or start to have negative behaviors during mealtime, you know, how is that parent reacting and how is that affecting the trajectory that we're on in this feeding process? And often eating is associated with pain, nausea, fatigue, and worry. I think worry is a big one. So the part with Arfid is that so often once the medical condition improves, that aversion might not. This may be someone who has had GERD, but they're still refusing food even though things seem to be well treated. Maybe they had eosinophilic esophagitis and it's being treated, but they're still in this process of refusing and avoiding foods. And so it can be really challenging to overcome. So part of the reason that challenging behavior can persist is this lovely negative reinforcement that I believe Darren's going to get into a little bit more. But you know, a child is not enjoying the meal and they throw a fit and then, hey, the meal ends. And so the child learns that this is a really effective way to get away from that thing that they don't want to do. And as it happens over and over, it becomes strengthened and reinforced, and it continues. Also, often parents are really worried or they have found that it's not successful to offer a variety of foods. So you do kind of get into this perpetuating cycle of, you know, there's limited exposure to food. So then the child isn't used to a lot of variability in what they're being provided. They then kind of have these different reactions when they are provided with a variety of foods and big outbursts, and the cycle of stress sort of continues. So then the family says, well, okay, I'm not going to repeat that. I'm going to go back to limiting their exposure, and it just continues and perpetuates. And then ultimately, what needs to happen is that the child needs pretty major intervention to make any progress in overcoming these behaviors and expanding their dietary intake, or they may need artificial nutrition support. So again, this is the part that our pediatrician, our gastroenterologist had worked on to share with pediatricians, but I thought it was important too. I made some modifications. I just think, you know, as dietitians, we can kind of go through our checklist. Again, if a family isn't saying my child has Arfid, if you see that they have eczema all over their skin, you may ask if they've had any workup for food allergy, because it could be that this child feels terrible and that's why they're refusing the food. Do they have GERD that's been untreated? Do they have potentially eosinophilic esophagitis, celiac disease, inflammatory bowel disease? Is there fatigue or any medical condition like a cardiac issue that could be affecting their ability to take food? Is there a genetic condition that may be affecting their ability to chew and swallow? And this is often probably gonna show up after kids are out of WIC, but is there a mental health condition that may be affecting their ability or willingness to be present and participating in meal times? We also want to be thinking about skills. And I think this is something that I feel so fortunate to be able to observe a feeding. Mostly I rely on folks like Julia to be getting the nitty gritty, but I do get to be present while a child is being fed, so we can really get a handle on what are their skills, because what you see is often very different than what parents report. Is there any choking or gagging, any color changes? Is the child having a hard time? Are they drooling a lot and unable to handle their secretions? That might be an indication that they don't have the skill to eat very much, and maybe the foods that are being offered are not a match for their skill level rather than just Arfid. Are there oral structures that need to be evaluated? Speech language pathologists and occupational therapists can help, and there's a lot of really skilled therapists out in the community who can do this. A modified barium swallow study may help, and it may not. You know, it's just a capture of a moment in time. It wouldn't make or break a diagnosis, but it can often provide some valuable information. It does not replace what was listed above in terms of a feeding observation or an oral exam. And I really like this. There's a couple of decision trees that are included in the presentation, and I was going to put a second one on here, and then I realized that Darren had it in his slide. So this is from an article on classification of feeding difficulties, and I really like the way that they present kind of the thought process about how we may be addressing what's going on. So you're sitting talking to a family, and they talk about a concern for an eating challenge. And, you know, we have height and weight if we're doing a WIC visit. We usually have their history. This is geared more towards physicians, so it talks about system review and physical examination. And then you kind of look and think, okay, are there things that may be going on medically, which is what I was saying earlier about, do we need to potentially talk to their pediatrician about a GI referral or an allergy referral? Are there things behaviorally that are happening that I think are really perpetuating this problem? And then what investigations do we need to consider? So if you go down to the bottom, I really love how we've got it divided into the child and the feeder. So limited appetite, the very first thing there is it's often misperceived. Some families will come in talking about Arfid, and if they eat 20 or 30 foods, we're actually going to say, congratulations, you've got a pretty good eater on your hands. What's their energy level like? Are they apathetic, or how are they acting when it comes time to meal? Are they just sort of showing up lethargic, or are they really fighting? And then down it does say, what are the maybe organic things to be considering: structural, GI, cardiorespiratory issues, metabolic issues. And then there's selective intake. And again, it's often misperceived. Families really want kids to eat quite a bit more variety than they're often ready to at their particular stage. So a lot of kids will come in, and there's a lot high concern on the part of the family, and then we have to do some digging to see, are they just mildly selective? Are they highly selective? Is it something as serious as Arfid? Fear of feeding. Again, sometimes it can be misperceived pain, sometimes it's colic, and infants, you know, we all know they're not communicating, so it's a whole lot of guessing, checking, and refining to sort of see how things are going. But are there any causes of pain? Is there esophagitis? Is there something going on with their motility? Are there tube feedings that may be affecting their comfort or their ability to eat? And then on that far right, we talk about the feeder, because it is so important. important, that dynamic relationship between the person who's doing the feeding and the child who is eating. You know, are they responsive? Are they controlling? Are they indulgent, or are they neglectful? I think you can all sort of infer what those mean. And Darren, if you don't go into that later on, I might ask you to butt in right now and give a little more detail. I think I'm going to take the silence to mean he gets to it.
Oh yeah, sorry, Sarah. I was just giving you a thumbs up. We're going to talk about those things in one of the slides that I have coming up, because I think that's a critical factor. Is that you know, parents bring their kids in because we're supposed to help fix the kids, but many times we're really analyzing or understanding those parent differences as well. And so we'll get into the complexity of that as I go forward for sure.
Thanks, Darren. I can't see any people. I just see the screen. So please know if you're sending me anything. I'm not getting it. All right. So again, we're kind of back to that approach. Like this was the piece geared towards the medical part when we talk about the medical, the nutritional, the psychosocial, and the skill-based. This is kind of that medical thought process. So the Arfid diagnosis does come from the psychology and mental health arena. Pediatric feeding disorder is rooted in the medical and developmental realms. So we do need to be kind of thinking through those going through that thought process of what medical things could be contributing to this before we just jump to Arfid and its behavioral and its refusal, and there's nothing else we can do. It'd be really sad to miss something that makes the child feel horrible and therefore refuse food. But it is important to keep in mind that we believe pretty firmly that children can benefit from therapy even before you've got that medical diagnosis, because regardless, there are feeding challenges going on. And we were talking about that, those kind of systems of refusal, that cycle of refusal and stress and worry, those can be started really early on. And if kids are involved in feeding therapy, then folks can be helping to hopefully lessen that impact. And then at the end, that the parenting styles, thinking about the parenting and feeding styles of the kids. So the priority, now we need to make sure that kids are safe for their eating, that they're getting proper nutrition, and that their behaviors are manageable. There's no standard treatment. The approach depends on the setting and the resources. So, you know, again, from the medical perspective, you could be, physicians could be looking at labs for nutritional deficiencies, screening for any medical contributing factors. A lot of the doctors some of the doctors that we work with use appetite stimulants pretty regularly, and they can be somewhat effective. They also work as motility agents, so it can maybe have a double-pronged effect. From our standpoint, you know, this is the overview. We'll get into more detail. Provide supplements as able. We may consider an oral supplement like a Pediatric or something, or even tube feeding if it's a really acute case. We're going to be assessing structures and skill, working on behavior and interactions to sensory properties of foods, misspelled there, sorry. And then recognizing and treating comorbid mental health conditions like anxiety or depression, so that we can kind of help these kids along. And with that, I'm going to pass it over to Darren.
So hi everyone, my name's Darren Janzen, and I'm the primary behaviorist or clinical psychologist on the OHSU feeding team. I don't say that I'm the primary clinical psychologist because you know, people get a little nervous when you start talking about that or using those words. So I often will present myself as a behaviorist. It's very good that you all have your screens off today, because what does a psychologist do? We analyze you. So you're not giving me any information to analyze you on. And that was really wise on all of your part today. I'm gonna just give you some props on that. But what does a psychologist like to do? We like to talk. And so if you all have questions as we're going through this, I'd love to just pause and reflect and interact with you all as you know, while we're on this visit, rather than feel like you know, we're just talking heads. So if you want to type into the chat, or you just want to break in and say something, I'll try to give some spacing along that to allow for those conversations. I think that's really the interesting part of what we get to do is talk with one another and help our patients understand themselves better. So my goal today is to help provide some of the framework that we use to evaluate and treat I talk about that, when does it stop being evaluation? When does it start being treatment? We do a little bit of both of those things for our patients and our families. And, the children and the teens that we work with are complicated. And I think that's what everybody feels like when they're working with certain patient populations. But I feel like we really are the complicated ones as a person who's worked in lots of other clinics. And we'll talk about the reasons for why I think those are such complicated patients when it comes to Arfid. It can take a lot of curiosity, right? So that's really one of the things that we all have, and this is wanting to understand what's going on. It takes curiosity in that evaluation process to understand the true reasons behind why people have difficulty with this eating process. And for every patient we see, we're trying to gather the clues to help us figure out those best ways to provide effective management and not just management, but improvement, right? That's our goal. So my goal today is to talk about that process from a behavioral lens as we're going through things. And I'm just going to keep hitting that button, Sarah, because I just hit it with perfect timing for what you did. And remember, I don't have control over that. So thank you.
I'll take it as my cue.
Yeah. So like most of the challenges we face in life, there's multiple pathways to the reasons why our patients have difficulties or differences in their eating. There may be some genetic underpinnings, such as flavor preferences or the fact that some individuals can be super tasters with higher concentrations of taste buds on their tongue. Or even the fact that we believe that there's some evolutionary advantages that have developed over human history to load into these present day challenges. I believe that to be true. When you do talk to families about that, it's hard to get them to understand that. But we know that some of these factors are complex as to why people are struggling with these things. So plus we know that experience shapes perspective, and that perspective affects our reactions to future experiences, right? So if a child's limited in what they will eat, that can make other foods taste even more unusual. They might be okay with chicken nuggets, but baked chicken breast, no, that is a no-go food for these kids initially. That may be too exotic of a food, so to speak, for some of the kids that will eat chicken in other ways. So or if there's some nutritional deficiencies, those can also impact taste. And, if you can't be around others who are eating, many of our patients with Arfid cannot do that. If you can't do that as much, then you miss out on learning from positive modeling. And ultimately, that's the number one way we learn is by the modeling we receive from others. So, it's interesting that we often find others in the family who also have eating differences as well. So we're asking about these things, and sometimes families are a little caught off guard. Why would we ask about, mom or dad's growing up experience or what kinds of foods that they might eat? But we find that there are these differences in other family members. And if it's a parent, many times they'll still be picky, but it doesn't cause major problems for them at their age. But they might have forgotten a little bit about what it was like when they were younger. And when we start talking about it, it starts to come back. And they may remember really struggling with some of these things as a child as well. Sometimes the facts that they were or are super tasters, even as an adult, can be really helpful for them. We recently saw a young patient with Arfid, whose parent was also a super sensory person themselves, and this ended up being helpful for them in their profession because they ended up being an exceptional award-winning winemaker. And those sensory differences were one of the reasons why they were so good at their position. So, it's not all bad, but it can be a challenge. And it's interesting to see how those dynamics play out within the families that we serve. So our goal is to really identify these differences, how they got started, but also to give hope to families that we work with in this process as well. We don't want them to feel stuck. We want them to be empowered to know what they can do. So I think this was the slide that Sarah was alluding to earlier, but I got to steal it to put into my part. And so this model really can help us conceptualize, or can help in our conceptualization of why the feeding challenges are occurring. So Dr. Kay Toomey is a psychologist, and her group, they're really leading some of the ways that we're thinking about this. So you can see the various questions that we can ask to help us get to an accurate diagnostic picture as we're interviewing or working with families. And depending on those answers, the answers to some of these questions, we can get to an appropriate diagnosis, whether that's Arfid or not Arfid. So one of the things we have to ask is the child's nutrition appropriate? That's going to be one of the key factors that we have to be thinking about if this is a diagnosis or a non-diagnosable issue. And if the answer is no, that their nutrition isn't appropriate, then we have to think about other things like, did the child have feeding issues as an infant? It's very common for our kids with Arfid that we work with to really have been normal in that first year and a half or 2 years of life, and then 2 to 3, where some of that selectivity and preference really started to kick in, and families started to notice differences and things became more challenging. And so we see a lot of kids in that age where they're 4 or 5, and the last 2 years have been draining for their family, but they didn't really have those issues when they were young. They were okay. And then another question that we get to is, how long ago did the problem start, or does the child have a skill deficit? Which many of the children that we work with do have skill deficits, but their challenge with eating is beyond what we would expect, even with the skill deficit that they're presenting with. So I do think that Dr. Toomey's model, and I don't know if this is intentional on Dr. Toomey's group's part or not, but it makes it seem like the only pathway to get to an Arfid diagnosis is through fear of aversive consequences. But I want to add that box of, it might not be fear of aversive consequences, although that can always be present a little bit. It might be sensory sensitivities, or it might be the lack of appetite. Certainly I can think of patients who we've worked with over the years who it's been one primary issue. It's the child who is afraid that if he swallows things, he'll choke or vomit. And that's that fear of aversive consequences. Or the child who just cannot handle the taste and texture, is not really afraid of things except for the fact that it'll be gross for them. But the sensory experience being different. And I can certainly think of some people who really don't have any appetite. They've never had any appetite. And there's others in their family that don't have that experience as well. So I think it's important to be thinking about the 3 different distinct areas as they're going through as pathways to potentially get to that Arfid diagnosis. So the feeding differences, are often woven in with other neurodevelopmental differences, which we're going to talk about more shortly. But in terms of DSM-5 criteria, if this exists in the context of another medical or mental health issue, then the severity has to exceed what we would expect with that other condition. So this can be really tricky, to be honest, because there's no standard metric by which we evaluate this clearly. Now, there are ways for me as a psychologist to look at how conditions overlap with other mental health issues, such as looking for normative anxiety levels within ADHD populations. That's different than patients who don't have ADHD. So we will sometimes be able to look at those differences, but we can't do that in the same way for eating differences yet. Maybe somebody will create that tool moving forward. So we tend to have to use our clinical judgment in this process a lot. And that's where a lot of our discussions come in with one another in the clinic to determine which direction that we're going to go, which is honestly really helped, through our calibration with one another. I think I'm a better clinician because of the calibration that Sarah and Julie and all the other team members in our clinic have helped me kind of have over the years. And I think you can only really get that within an interdisciplinary clinic model. And, I think as we were talking about this earlier, we were talking about it in kind of a multidisciplinary approach. you know, I would actually say that we're maybe even beyond that, and I would say maybe even beyond an interdisciplinary approach. Sometimes I feel like we're a transdisciplinary approach where everybody is kind of saying, hey, did you see that behavioral thing? Or, well, you know, well, we should do this behavioral trick. It becomes a little hard when some of the people I work with are better psychologists than me, professional as well. And we're having these conversations, we start to understand all the different roles and how they connect. And hopefully my internet is saying it's unstable. Are you able to hear me okay, everybody? I can see you, Sarah and Julia. Can you guys hear me okay? Okay, good. Maybe it's not my internet.
I think it might be mine.
Okay, got a little nervous there that you couldn't hear any of the amazing things that I was saying. Good. If I do, just start sending some messages to me. So hopefully you didn't miss out any of the brilliance there, but if you did, I'm probably lucky. I think we'll move on to the next slide.
I'd like to actually interrupt for just a second before we do. Oh, crud. I guess I don't. What am I? I'm going the wrong way. So just keeping in mind that we are talking to a group of dietitians here, I think it's really important when you look at the top question there, is this child's nutrition appropriate for his or her chronological age? That's the first question. And while, you know, we're talking about interdisciplinary or transdisciplinary teams, the first tier you all get to help determine is this child's nutrition appropriate, yes or no? If the answer is yes, then I think we can really do a lot of good by then going to down to that next question and saying, hey, okay, so how many foods does this child usually eat? And if this child is more of a typical eater or a picky eater, right away, if we can help to explain that to the family and let them know that the nutrition is okay, we can really alleviate a lot of stress and some of those other complications of going down sort of this medical track and having just setting ourselves up for more challenges. So don't discount the power of that critical thinking about, does this child seem to be uncomfortable, and then really how many foods do they eat? This may be actually not nearly as bad as they fear.
Yeah, and I think that's important even for us professionals at times. You know, if it's your kid, you know, you worry about things in a different way. And so, you know, our families come in without the knowledge or expertise that we all have in our specific domains. But even those of us who have this knowledge, sometimes we still worry about these things, and we just need a little bit of support to help us understand how much we should be worrying about these areas. So, you know, part of you know, the process is getting to know people, right? So it can take really a long time to get to know and understand people in life. And that's no different with our patients, but we're all trained to do this as efficiently as possible, right? Sometimes we have a very short amount of time to be interviewing and gathering information and making decisions that are really critical to patients' care and the directions that they go in the future. I feel that there's an art to not only asking the right questions, but fostering openness and trust in both patients and parents that we work with. These are some of the questions that I always try to ask in order to allow patients and family to tell their story and feel heard. And I appreciate that somebody just said these are great open-ended questions. Thank you for noticing that. You know, we also want to be cautious in what words or what questions we're using to keep people from being on the defense. So, you know, these are just some of the things that I try to think about. Help me understand what happens during meals. I really want to understand that process, or you know, what have you learned that's the best to do when your child won't eat, or how worried are you at this point about their eating? Is that worry shared by other parents in this process too? And oftentimes when we're asking those kinds of questions, we're able to get a lot of information because the family will start to divulge things. And sometimes what they don't say also tells us information as well. And so that's part of that deeper digging process of getting to know and understanding people in this approach. So, you know, high stress environments, They don't tend to be helpful for patients with Arfid. So it's much better to have clear expectations and predictable responses for the choices that children or teens make. A responsive parenting, this comes back to what Sarah was kind of talking about or had on the slide earlier, that we want to be trying to pushing families closer to that responsive parenting category. I'll be honest, these are not categories that we're in all the time. I probably am in every one of these categories at least once during the week, maybe twice during the week, if maybe more if you ask people in my family. But it's the goal isn't to always be in a responsive parenting role. It's to recognize when we're getting outside of that and finding ways to pull us back into that space. So responsive parenting styles have high expectations, but also high support. Controlling parents have high expectations, but very low support. The flip side of that, indulgent parents have very low expectations, but very high support. And neglectful parents are actually parents that we don't see very often in our clinic environment, at least not with the parents who come into our clinic environment, but those are the ones who have low support and low expectation. They're really not providing any framework, any structure, or any help in the process. So we tend to see more parents in the other three categories, not in the neglectful category. And sometimes each parent in the household falls into one of these opposite dynamics as well, which can make it really difficult for our patients to improve. Like if one parent is controlling, then the other parent may intentionally be indulgent to balance that out for their child. And that doesn't create an environment where a growth is likely to occur in the ways that we want. So our goal is to help families feel validated in the struggle and to educate them in the different approaches that patients with Arfid can improve in. That's our primary goal in the visits that we have. But oftentimes, this really goes against how parents were raised themselves. It's so common for us to hear the idea of, when I was a kid, I was told to clean my plates and I had to sit at the table until I was done, and all these kinds of things that parents kind of went through. But the reality is these are different times, and we, just like different times in terms of what we should have expectations for in our kids are learning and thinking and behaving differently than I did when I was a younger child too. So because these are different times, we really try to help families understand what's needed for long-term progress in healthy eating, and not just healthy eating, but positive food relationships, right? That's our goal, is to have kind of the balance between those two things be obtained. So it's an ongoing process, and ultimately, in my opinion, it all starts with listening and helping those patients feel understood so that we can get the real story of what's going on in this situation. So once a person gets stuck, right, in anything in life, it can be hard to work past these challenges, right? So that doesn't just apply to feeding, but that's in other areas of life as well. For us who are on this call, we can all get stuck and have a hard time getting moving. But for patients with Arfid, for the patients we work with, there are often multiple physical or emotional reasons that are the foundations for these differences. So although, we know that as adults, we know logical thinking and approaches tend to lessen these challenges, most of our patients with Arfid, the patients that we see, have had experiences that make them resistant to our logic-based arguments. My mentor used to say, a person with an experience will never fall prey to a person with an argument. And I think that's true, that their experiences are really what's underlying their perspective about these food experiences for themselves, and we have to help them have a different way to work through this than just arguing them that you'll like it. I'm sure this is just like your other foods, because their experience may be somewhat different. So we know that only a new, positive, or neutral experiences can overwrite old negative experiences, or really rewrite like a lack of experience, because we all know that no experience can make things seem super difficult. you know, my only experience with sharks is knowing what I saw in movies. I don't really have an experience with those things, and those things terrify me. I'm sure if I was with sharks, they'd still be terrifying, right? We'll just agree to be afraid of sharks. But, you know, I think most of that, my fear is based on watching Jaws as a kid. Don't let your kids do that for sure. So we want to give new experiences with that. Maybe tiger sharks or those nice ones you swim with. That would help people not be afraid. You can get a child past this I can't wall, right? And you can do it in a way that leads to long-lasting success. But you can't do it by using the same emotional tactics that made the wall happen in the first place, right? So you can't use guilt, or you can't use shame, or you can't use disgust. Those kinds of tactics are just going to make that wall higher for the families or for the patients we work with. And many of the families that we work with try to use those kinds of pressured tactics to get their children to improve. So all of these reasons can lead to pressure or stress. And we're really talking about fight or flight responses, and maybe a third as well, like a freeze response in this situation. And so we have to be thinking about how people respond to these kinds of situations. That the formation of fear-related memories is important to be thinking about in this, because it's really involves the strengthening of neural pathways between brain areas, and the two primary ones are the hippocampus, which responds to a particular context and encodes that memory within our brain, and then the amygdala that triggers those defensive behaviors, including fear responses, when that particular context arises again, right? So we're trying to work past those kind of automatic responses that kids have had instilled in them from a very early age due to the pressure or stress that they have. And we can unwrite that I can't wall, but we have to help families know how to do it in the right way. We're understanding more about the complexity of patients with Arfid. This information is taken from a recent retrospective study in order to better understand these complexities. So in this relatively small study from information taken at one eating disorders day treatment program, the researchers found that sensory sensitivities was the most common factor for patients with Arfid. So the role of OT in working with patients in Arfid is secure. They also found that over 50% of the patients, for over 50% of the patients, there were co-occurrences with both a lack of appetite and or specific fears. So many of the kids that we see, it's not one pathway that causes Arfid, it's all three. That creates more complexity in the approach that we have to take to help them overcome this. They also found an overlap of Arfid with other neurodevelopmental disorders, with approximately 39% in this program having autism and 10% having ADHD. If these patients just had one pathway or one challenge area, they might be easier to treat. But this information really points to the fact that multiple factors can affect the eating process and ultimately lead to the diagnosis that we give of Arfid. So, and this becomes part of the challenge. You can treat feeding disorders, but you can't treat feeding disorders like Arfid separate from these other differences. Plus, it can lead to challenges in, is reverse genetics a thing? Thinking backwards, I don't think reverse genetics is a thing. We're gonna say it's a thing for the purposes of this. In that, what our kids are struggling with oftentimes show up in the parents as well. Many of the parents that we work with also have their own challenges. Like take ADHD. If a child has ADHD, there's about a 50% chance that a parent does as well. So, we really have to work to support the whole family system to better manage these other issues that can affect eating. There's other factors we won't even have time to get into today, like the differences that medications may cause in terms of some of the factors that our patients with eating differences struggle with. And yet those things are really important for other factors as well. So lots of complexity in patients with Arfid, and we're really glad that there's at least a way to conceptualize this in a fashion that tries to convey that complexity, whereas 10 years ago we didn't have that way to do that diagnostically. So lots of complexity, multiple pathways in terms of those sensory, appetite, or fear-related differences, and many other comorbid challenges that can cause these to be more difficult as well. So my goal in what I've discussed so far is to lay some of the foundation, right, of understanding the challenges for Arfid. I don't want to say this is so difficult that we're entirely stuck with it. You know, my goal as a psychologist is not just to tell someone what's wrong, it's to support people in understanding and changing behaviors that keep them stuck, right? I'm a therapist at heart. You can't be a therapist without some of that optimism coming out of you. So, you know, if we think about each of these categories that can cause patients to struggle, we can develop sequential steps towards improvement. So for sensory differences, we try to foster a systematic approach to sensory desensitization that minimizes total avoidance, right? Many of our kids are masters at avoiding things. We hear that all the time from the patients we work with, and we want to minimize that. You know, you can't take away avoidance entirely. We just want to find ways for them to avoid less. And then we keep building on that process. So Dr. Toomey's Steps to Eating, if you've all seen that, are the guidelines that kind of outline this process really well. You can Google Steps to Eating and it will come up pretty quickly. You know, we start with tolerance as a first step, just being around food that other people are preparing or eating. And then we sequentially help the patient with Arfid handle more significant exposures, you know, from tolerance to interaction and through the sensory experiences, touching, smelling, tasting, and eating. For challenges with fear, we often work to help families understand the role that avoidance has in keeping our anxieties at a high level. So the goal is to create fear ladders or fear hierarchies that patients can climb sequentially to push back against their fears and learn that they can remain safe, even in doing some of these difficult things. You know, we don't advocate for flooding or throwing people in the deep end of the pool to learn to swim. You know, this is a process that, you know, that we're really talking about, sequential process, though, that does help patients and their parents learn that they can have control over their fears and not let that worry bully in their brain, you know, that little part of their brain trying to keep them stuck and telling them things that are making them a little nervous or uncomfortable or disgusted with things. That worry bully push them around and keep them from doing things that they're capable of. You know, that's really hitting on something that's a little more sophisticated for the kids that we work with, but it's trying to correct cognitive distortions. Many of the patients we work with have automatic thoughts that make them resistant to wanting to do the things that we're asking them to do. And those automatic thoughts are not always in line with reality. And so we try to help patients in age-appropriate ways understand when their thoughts are distorted and helping them have more realistic thoughts about that through the experiences that we're working with them in. For appetite, for when it's limited appetite, we work to keep them on a meal or a snack schedule. Sometimes they have to use an alarm if needed. One of our patients, if he didn't listen to his alarm on his iPhone watch or his whatever you call Apple Watch, he then would forget again and go on and then realize 3 hours later he still hadn't eaten. So, you know, we have to help them sometimes have alarms that they then will do things. They're agreeing to do things to stay on a meal and snacks structure. So the goal is to really minimize any grazing that might be happening and allow them to have more of that stomach full and stomach empty experience. You know, we might also use things like interoceptive exposure practices, which involve strategically inducing somatic symptoms that may be associated with being kind of uncomfortable or being anxious. In fact, one of the patients I was just talking with is a 14-year-old with Arfid who is so terrified with feeling nauseous when she eats. And what we'd have to help her realize is that's not, you know, a terrible thing. You can have a stomach ache and be okay with it, or you can feel nauseous, take some deep breaths and let that feeling pass. So our goal is to help people have those issues kind of induced, and then encourage the patient to tolerate it without distraction. So not watching, Netflix on your iPhone, but without distraction, to understand this isn't a major problem. I can handle this. I can do hard things. So our goal for patients is growth, right? It's not just in the physical sense. We want patients, even in the limited time we have with them, to know they aren't the only ones, and that there are things that both their parents and they as patients can do to help these things be better managed as they're getting older. And I think that's where I'm going to turn it back over to Sarah, unless there's any questions or comments anybody has to make at this point.
All right,
Perfect.
thanks.
Thank you, everybody.
Thanks, Darren. Okay, so nutrition and Arfid. I think hopefully one of the messages that you're hearing right now is that with families, we do want to help them to not feel alone and to help to ease some of the anxiety and concern whenever we can. And speaking with my fellow dietitians, that's my goal for all of us to know when to be afraid, to know where to focus our attention, and really to know when we can kind of relax and say, yeah, this is hard. We understand that it's hard, but should we be worried? And when should we be worried, and when shouldn't we be worried? So these are kind of my steps to the nutritional assessment for Arfid, and I'm going to go through these. Description of meal times, as Darren was saying, that's where we start. We, of course, will be looking at the growth chart, and we'll talk about what we can learn from that. Really kind of taking a deep dive into vitamin and mineral intake to see, what we know their diets are pretty poor, so which are the ones that are of most concern. Going back to the earlier information, thinking about the possible medical complications associated that could be contributing to the food challenge. And then even if none of those things, if number 2, 3, and 4 don't really reveal anything, we're still going to go back to the description of the mealtime and say, yeah, okay, so it's hard. What can we do? Do we need to refer to additional supports, or do we need to provide some reassurance? So we know that diet quality is poor. I'm guessing your experiences are similar to mine, that when you're talking to these kids, they really have a preference for kind of white, starchy carb foods, usually very low fiber, very little consumption of fruits, vegetables, meats, very few mixed dishes. These foods are typically packaged and known. So every time you open a package of this cracker, you know exactly what it's going to taste like, versus spaghetti might be prepared in 75 different ways, and it's going to be a little bit anxiety inducing each time. What we don't know necessarily, what I'd like to talk about a little bit today is, so the diet's poor, but which tools can help us assess nutritional status? How prevalent are serious complications related to the poor intake nutritionally of people who have Arfid? Are the nutrients we should really be the most focused on? And then are there acceptable ways to fill these gaps? So first tool, this is probably what you all will do before you pull your families back, or before you sit down and talk to them, is pull up your growth chart. And I think it's really important to note that growth for people with Arfid is all across the board. There are people who have Arfid who are overweight because they are restricted in the variety of foods that they eat, but they eat really large amounts of those, I don't know, I'm going to say Cheez-Its and Nesquik. And there are people who are underweight because of the type of Arfid that they have. So quite honestly, for most cases of Arfid, the growth chart is not all that helpful. The one exception I would say is, if we're going over here, looking at these 3 types of Arfid restriction, the variety restriction, again, you can have a healthy weight or overweight status. If someone is restricting both their variety and their volume, you might see chronic low weight. But in those earlier slides that Darren was talking about, Dr. Kitumi, she really focuses on Arfid as being primarily linked to this 3rd subtype of Arfid, which is the post-traumatic food restriction. And those are kids that have an acute fear, it's sudden onset, and it does result in rapid weight loss. So that's the one time where the growth chart is really beneficial. But the rest of the time, it's just kind of a piece to our puzzle, but not a major player. So a healthy BMI does not indicate whether or not feeding or behavioral supports would benefit a family. So kind of knowing the audience and what we were after today, I actually did a deep dive into the literature to kind of say like, okay, the questions I have are probably the questions that everybody else has out there. Like, how bad are their diets? How bad are people's diets with Arfid? And how worried should we be? So what are these kids' nutritional intake like compared to some of their same aged peers? And there are a few studies out there on this. And I've listed a couple that were pretty representative to those that I found. And they're both on this slide. So I've divided it to a Harshman study out of the United States on the left and a Schmidt study out of Germany on the right. So on the left, the population and the design, these were kids that were in the United States. They were healthy weight individuals with Arfid, and they had 52 people with Arfid compared to 52 healthy controls. They looked at 4-day diet recalls, and when they did that, they found only 2 nutrients of significant difference, and it was vitamin K and vitamin B12. So immediately, we're all probably thinking, not too surprising, dark leafy greens and meats. And then if you go to the right, this is a study out of Germany, and these were individuals who had Arfid who were seeking treatment, and they tended to be of normal to low weight. There were more low weight people in this study, and they took 3-day diet recalls and food preference lists. They had 30 of their study subjects and 30 healthy controls. And in this, you can see there were more nutrients that were significantly different between the two groups: calories, B vitamins, vitamin C, vitamin K, zinc, iron, and potassium. So I think that's interesting, but it led me to ask this question. So these are comparative studies. We know that particularly the one in the United States, there were just those 2 nutrients that were of difference, a significant difference. So how great were the diets of the controls? So this is just kind of a little bit of an overview here. You're all probably familiar with this, but we look at the Healthy Eating Index score, which is a data-driven assessment quantifying diet quality. So the dietary guidelines just came out, and this is kind of a measure to see how well are we doing in achieving those aims that are set by the dietary guidelines. And when people's diets are reviewed, if someone got a score of 100, it means every single thing that they ate and consumed and documented was in alignment with the dietary guidelines. A score of 0 means nothing was in alignment with what is recommended. So when we look at our Arfid age group, for ages 6 to 11 and 12 to 17, these folks are scoring a massive 53 out of 100. And it's really, really important to note that this is not Arfid specific data. This is general population data. So overall, Americans are getting a failing grade on their Healthy Eating Index scores. So then on the studies that I had posted previously, I know this is a lot to take in at first, but I'm gonna, if you look at the very top, I'm gonna draw your attention to the column on the right. So this is the percent not meeting their dietary reference intakes. So if you go down, you can see you've got your Arfid kids and our healthy controls. I'm just gonna focus on our healthy controls. 63% of our healthy kids didn't meet their vitamin A. Half didn't meet their vitamin C requirements. 92 didn't meet vitamin D. 84 did not meet their vitamin E. Vitamin K was one that did get marked as being significant difference, but over half of the kids who were healthy controls did not meet their recommended vitamin D intake. And it just down the line goes on and on. The B vitamins, roughly 1/3 of the healthy controls didn't meet their recommended intakes. 2/3 didn't meet calcium, half didn't meet iron. Magnesium, 2/3 didn't meet, and I'm sorry, 3/4 didn't meet, and then with zinc, we're at roughly half. So I think that's a really important piece of the puzzle, that when you're looking at nutritional intake of kids with Arfid, it's not just vitamin K and B12 that we need to be worried about, but it also makes me think, hey, we need to be considerate about nutrient intake with all of the kids that we're working with. And we also need to be really careful about holding our kids who have Arfid to a higher standard than we are the rest of the population. If we were trying to get the kids with Arfid to meet 100% of their dietary intakes in every nutrient, with this information in mind, I'm starting to feel like that's maybe an unfair goal to put on them, knowing how challenging it is. And now this is that same idea of comparing the diets with people who have Arfid to those who do not. And this is from that study that was previously up on the right, the study out of Germany. And so the way that they have this written is the achieved percentage of vitamin and mineral intake that was consumed. And so we're going to come back over here. I don't know if you can see my cursor, but in the control column there, the second one from the left, again, the controls were getting like 40 to 60% of their B vitamins. They did great in vitamin C. They got 5% of their recommended vitamin D, really low intakes across the board on all of these nutrients. But when you look at the column for Arfid over on the right-hand side, I think what terrifies me probably the most is when you look at the range on the far right, there were individuals who got 0% of each of those vitamins in the top. Everyone got at least a teeny amount of minerals, but there are definitely some severe restrictions that take place in our kids with Arfid. However, again, the control population had pretty crummy diets themselves. So then we're thinking, okay, we saw those kids who had no intake of any of those vitamins. So what is the prevalence of severe medical complication related to self-restricted eating? And I think that's my big fear. I don't know about you guys, but when I'm talking to someone and they're only eating, you know, like what, Cheez-Its, Ritz crackers, and I don't know, something else, gummy bears. What is the big thing that we're going to face if we don't correct this poor nutritional intake? And so out of our own Journal of the Academy of Nutrition and Dietetics, there was a systematic review that was published just this year. And remember, the diagnosis of Arfid just arrived on the scene in 2013. But what they did was they went back to case reports and case studies predating that diagnosis, but looked at the criteria, or looked at the looked at the characteristics of the people who were in those case reports and case studies and applied the criteria to Arfid to them. And so over 65 years, there were only 76 case studies that have been written up and published about severe complications related to malnutrition in the presence of Arfid. And when you look at what were the nutrients of concern, 72% at the time, the nutrient that got kids into trouble was vitamin C, so the old scurvy. And in my 11 years at the CDRC, I have seen one person who was diagnosed with vitamin C deficiency, and that was also the one person that I have seen who was vitamin A deficient. So those top two nutrients I've seen deficient personally that I can recall in one person. And he was a teen and had a pretty strict diet of a couple of loaves of white bread and 2 liters of Dr. Pepper a day for many, 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 many years. And that's pretty representative. This study that's linked down here, this review, it's pretty cool. It goes through each of the kids and it writes out what they ate, and so you can get a look at, usually most of these kids had about 3 foods that they were eating. So then we also have vitamin B12, vitamin D, and thiamine that may have been nutrients of concern. But I think it's important to keep in mind that of those 76, these were extreme cases that involved hospitalization. I can think of that one person who's been vitamin C and vitamin A deficient, but over the years, so many, almost everyone that you check has a vitamin D deficiency. You all do tons of screening for people who are at risk for iron deficiency. We can do a diet recall and pretty clearly identify if there's a strong risk for calcium deficiency. And I have seen some zinc deficiency as well. So I think it's really helpful to have this information on these studies and what got kids hospitalized, but we can't throw our common sense out the window, and we have to remember these kind of less exotic culprits that we face more regularly as well. So this kind of goes back to what I was saying earlier when we were comparing the diets of people who have Arfid to the healthy controls. And I like this, we, in our minds, we're all aiming towards this happy family who's eating together. And of course, we've got this bowl of like crisp, luscious salad, and that is what success looks like. And that's pretty far-fetched for a lot of our families. And so I would like to sort of redefine what success often looks like, and what the interventions that I recommend look like more often than not. If you have kids who are eating just a few foods and you know that they're at risk for insufficient nutrient intake and multiple nutrients, it's going to be so much easier for them to become able to consume on a regular basis a highly fortified, known food that's going to taste the same no matter what, or a vitamin that is a known entity, than to say, all right, here's your my plate, and you need to eat 7 vegetables and 6 fruits and 5 different grains and 3 different proteins. That's going to take potentially years for kids to get to that type of variety. And so I spend a lot of time really focusing on what success is and looks like for me. And for me, success would be avoiding the nutrient deficiency, finding some really highly fortified foods that they can fill in their nutrient gaps with, while overcoming the fear and the anxiety associated with eating, without increasing the pressure, by saying that they have to eat a huge variety of foods. I think I say this in every presentation, but with this group, it's particularly true. A lack of nutrition knowledge on the part of the parent is certainly not the root of this problem. So the last thing that we need to do is give them a big lecture about providing a variety of foods. What we really want to do is help to alleviate stress, normalize what we can, and then give some practical tips to avoid that real dire situation of a micronutrient deficiency that's severe. And I think this just kind of plays into that. There are a few studies on really small sample groups that talk about intensive interventions for individuals who have Arfid. They're usually 12 to 16-week sessions. It involves the parent and the child. And usually when the intervention is over, almost always parents report great satisfaction. They're thrilled with the training that they got. Almost always they're reporting improved behaviors and interactions at meal times. The parents feel like they feel more confident in their ability to feed their child and help with the behaviors. But the dietary changes almost across the board remain very insignificant. Again, these are usually pretty small sample sizes, but generally at least half of them haven't changed their nutritional intake. Sometimes they will have, one person started to drink water, and which is great for hydration, but no other nutritional change took place after that intervention. Sometimes kids will grow to accept various brands of their previously tolerated foods after this intensive intervention. And occasionally they will have picked up, as many as 20 foods, which has got to feel huge for these families. But even with really intensive intervention, I think it's just worthwhile noting that the behavior is improved, the nutrient intake is fairly unchanged much of the time. And so that's why I'm going to circle back and remind the families and all of you that I do think the most bang for our buck can be those fortified foods, which luckily, you know that in WIC you are able to provide access to those fortified breakfast cereals, and then guidance, particularly on, or potentially on, some vitamin and mineral supplementation. So, if you've got a physician on the line and they're really worried, these are the things I think about when you're talking to someone about a really severe long-term restricted eater. You might want to draw some labs. You could consider chemistry, an iron panel, a complete blood count. You might check vitamin D. And then again, these are things I have checked. Zinc on outpatient. I've checked B12 for people who, whether by their accepted foods or by their family lifestyle, follow a vegan diet. I've never ordered a vitamin A or a vitamin C as an outpatient. I have seen those drawn inpatient, but those would be kind of the exotic labs that you might want to draw. But the first line of defense, pediatricians are usually going to be running those on the top line there. For the diet, again, this is not a lack of nutrition knowledge on the part of the parent. Usually the parent's anxiety is through the roof, as well as the anxiety of the child who's being asked to eat a variety of foods and outside of their comfort zone. So reassurance whenever you can, even if it's just that reassurance of you're not alone. I've talked to other families who have experienced this too. I know it's hard. I hear that it's really challenging. I'm sorry that you're going through this. Sometimes just that can help them to feel, they do often feel really isolated and that they don't know people who have experienced this. We can be talking about vitamin and mineral supplements or fortified foods. And there are times when we might consider oral nutrition supplements if weight and micronutrient intake are really poor. I think so often the kids that I think of who I do this for are individuals who have who have autism, but if they do have Arfid and low weight and a really poor diet, then it is a case where I would say, yeah, you need that. We can't get anywhere. All the food recommendations that I've made have hit dead ends, so that might be something to consider. And then goals, we want to be referring to therapy, which Julia will talk about more in just a moment. We want to provide that reassurance. The nutritional intake will not improve until medical contributors to Arfid and stress and anxiety are addressed. So we don't need to jump in with a ton of nutrition recommendations right out of the gates. We kind of need to get that other foundation settled before we can start working on building a healthy diet. Now I'm going to pass it to Julia.
All right. I'm Julia Farrell, and I'm an occupational therapist and lactation consultant with the feeding clinic team. Originally, this slide was supposed to draw your attention back to a study that our GI doctor, who was talking in part of the part that Sarah did in the beginning, had brought up. But that part didn't make the cut, and I couldn't cut out this slide because it was specially made for me. It has OHSU streets on it, and so I left it in regardless. Doesn't make as much sense as it did in the original presentation. But the reason I brought that up is that there was a study that Dr. Doan presented on. Sarah, if you could advance the slide. In the 2018 Hospital for Sick Children. And there's a number in that study that stood out to me as a feeding therapist on the team that both broke my heart and made me feel like I needed to present some information about that. They found that 46% of the children that they studied had been having a feeding disturbance for approximately 2 years before they received an evaluation. 2 years is a long time in the life of a kiddo, and I'd like for us to think about a few things as to why it might have taken 2 years for them to receive an evaluation, what those 2 years might mean for the child with pediatric feeding disorder or Arfid, and what you can do to support families in reducing the time that they're waiting for the assessment. So why does it take 2 years? There are a lot of really good reasons. Pediatricians and other people like you all likely hear about concerns from parents with their children's feeding all the time. There have been some studies that talk about this, and they found that they're in our references, and there are a number of them, but on average, depending on the study, between 20 and 50% of families mention feeding concerns, even if their child has no other comorbidity, no other developmental concerns. Feeding concerns are on the top of their mind. When we add in children with developmental concerns, that number goes up dramatically to anywhere between 70 and 89% of those children parents have feeding concerns about their child's eating that they talk to their pediatricians about. The other reason it might take 2 years is that if they're growing, it can't be that big of a problem, can it? And when we think this way, I think all of us have talked about this to some degree in our presentations. We think there can't be any pathology if growth is adequate. We sometimes miss how hard families are working to make that growth happen. We also may not be paying attention to highly restricted diets like we've been discussing, or over-reliance on milk, or over-reliance on substitutes like Pediatric. And then the last reason I think this happens a lot is that the developmental screening tools about feeding are just not that sensitive. In pediatricians' offices, there are a few self-feeding questions that are tucked into some of the developmental screeners that they use. And they're not talking about true feeding development. They're talking mostly about feeding skill, self-feeding skill development. And so a lot gets missed. So what could those two, yes, I hear that in rural Oregon, yes, okay. It can take a long time to get appointments, absolutely. That's a really huge problem in our communities. It takes a long time even in Portland because the teams are all really impacted. So what does this waiting do for a family with a child with PFD or Arfid? They're having meals 3 to 6 or more times a day, especially if they're grazing. They are experiencing stress every single one of those times. That stress is feeding the worry monster that Darren talked about, and parents are trying to avoid the stress and adapt as best as they can. So we get a lot of avoidance. So what can we do as community providers? I think there are some simple things that we've already talked about, but one of my very favorite is on the next slide. It is the infant and child feeding questionnaire screening tool. And this is something that's free to families if they have internet access at all, or if they could fill it out in your office. It adjusts for prematurity for young infants. It does all the math itself. You don't have to add any of those numbers together. And it's available online at feedingmatters.org. The questionnaire is an evidence-based tool that was built to help identify feeding disorders and try to identify them early. It provides parents with the education about infant and child feeding development, so they will gain information about what is typical and where there might be concerns. And then it provides them with talking points to take back to their pediatrician. The other thing I think we've talked about a fair amount is to consider that adequate weight gain and growth do not equal functional eating patterns and mealtime participation. We've talked about our children with autism. They're a great example of this a lot of the time. They might be in the 80th percentile for their height and weight. Their BMI is great, but they eat 3 foods. It has to be presented in the exactly right way with the specific plate and a specific cup, and it has to be the just right temperature with the iPad with a very specific video on. And if any of those pieces are not present, they just can't eat. And may be very upset. The next thing that I think we can do is pay special attention to certain children and families. If children have a history of nursing difficulty, if that difficulty was not related to milk supply or for other reasons from the nursing parent, if it's a baby-driven problem, I might want to follow that kiddo a little more closely as they develop in their feeding skills. If it's because their state regulation was poor and they couldn't wake up enough to nurse, we might get them through that early feeding period and get them growing and be okay, but then we might see another bump in the road later on. So when I have those kids come to see me in feeding clinic, I might be able to give them the skills, but then I might want to keep my eyes and ears on them just to make sure they meet those developmental milestones as they're progressing. We've talked about slow weight gain and a low appetite that is obviously somewhat connected to that. And then any difficulty with transitions to purees, weaning from breast or bottle, or solid food transitions. Those are periods of time when hiccups happen in feeding processes and development, and could lead to a choking episode or something like that that might cause more anxiety and decreased participation in mealtime. And then any other motor or language skill delays. This isn't specific to the children with autism, but those are just kids that I really like to keep my eyes and ears on. I am going to mostly skip this next slide because I think we've talked about that. And thank you, Sarah. Go on to, oh, nope, the one before that. Refer to feeding therapy. I think we've given you a bunch of questions to already ask, which was my previous slide. Darren had the open-ended questions, which were very similar to the ones that I was suggesting. But referring to feeding therapy is early if you can. I definitely understand the frustration with finding feeding therapists in rural areas. I do have lists of providers, so if there is anyone that would like a list for their area and don't have access to those people, I would be happy to share them. I'll type my email in at the end. And if they cannot find a provider locally and need a referral and are able to come to a larger center, telehealth is helping us make inroads into areas that we could not have done before. And I'm really, one of the silver linings for me as a therapist for COVID, that I can pipe into families' homes and be a fly on the wall during mealtime. Then the feeding therapy evaluation involves all of these things. We do a thorough medical history, look at all of the development, oral motor skills, assess for swallowing dysfunction, sensory processing issues, mealtime participation, behaviors, family and child interactions, levels of family stress, and of course, addressing family goals during those times. And the therapy process is complicated and it is really dependent on the child and the reason we're seeing them. My main role on the treatment team is to help children and their families down the path of making mealtime less stressful. The way I do that is helping the child and family become independent with practicing those processes. It might involve more coaching for some families, specific skill development for others. And I try to increase interactions with food for the child while reducing their stress levels during that interaction. I might increase or decrease the demands of the task based on the stress level that I'm seeing. It's helping them sort of walk up to that line of their worry wall, like Darren was talking about, and then, oh, what if we do this one thing that might help you put your toe over the line, or get closer to that, breaking that wall down. The biggest and most important part of this whole slide is trust. So I have to build trust with that child. That's the reason that's the biggest word in the slide, because without trust and without the child's buy-in, I don't get anywhere with therapy. I'm just continuing to help them build up that worry wall. So I try to avoid doing that. And then I wanted to leave you with this slide because I feel like it perfectly explains my process in feeding therapy. You can't go back to change the beginning, but you can start where you are and change the ending. And that's the way I see my role on our feeding team, trying to help parents and children have a functional and calm, hopefully, mealtime process.
Thanks, Julia. I just wanted to point out that we are pretty close to the end of time here, and we do have a case study, but I feel like we can skip that unless, yeah, I think we can skip that and open it up to discussion and question and answer unless people had, I don't think you have your heart set on the case study.
I think it's there that you can look through what some of the specific guidelines we would all be kind of recommending for our patients, but I agree with you, Sarah. And there was a really good question in the chat that I think we should make sure we're answering as well. Is the goal for increasing number of foods to approximately 20 age dependent, or just increasing the number of foods as much as one can?
I can take that. If you guys are okay with it. I think what I would say to that is we can't have a firm number like that. We have to meet the child where they're at. You know, yes, it would be amazing if we could get every child to about 20 foods, and we may feel that the nutritional variety was sufficient at that point, but it still would require an assessment. So I think that's kind of an aim, but not a hard and fast rule. I hope that doesn't feel like I'm avoiding the question, but we can only get as far as they're going to let us.
I think for a lot of our patients, we're not trying to develop foodies, right? People who just want to try everything. Sometimes that does happen, but I agree with what you're saying, Sarah. Our goal is just to help people grow and do the things that they need to be able to do to fulfill the life goals that they have. So some people might be fine on 20 foods. There are plenty of adults that we see as parents of these kids who don't have more than 20 or 30 foods and they function just fine, doesn't impact them. But we want to keep pushing our kids to grow as much as they can.
Mm-hmm. And then I see a question that just came through from Greg mentioning feeding therapy being recommended even if Arfid isn't yet diagnosed. So I think what that could look like on the community would be asking if they're involved in feeding therapy, you know, when you're interviewing the family. And if they're not, a lot of the kids that we are working with are getting their feeding therapy through early intervention. And I know that your organization is in such great contact and communication and support of early intervention. So seeing if they can get connected with early intervention for an assessment, and then maybe just letting them know that occupational therapy, or if there is someone who happens to specialize in feeding, that would be a great service to request. And then beyond that, it might be communicating with the PCP, or if there is a community health nurse who's working with the family, trying to see if they could help to facilitate a referral. And Julia has lists that she can share if you're unaware of people who provide therapy in your area. I don't know if everyone can see. Elan says that ECN referral would be good. Ooh, vitamins. Sorry, do you find that labs for vitamin and mineral deficiencies are not covered by insurance? I don't know that. Oh, thanks, Cheryl. I don't know if they're covered or not, because again, it's not something that I'm going to check that often. If I'm worried, I'm probably just going to recommend a vitamin, because does it matter? Does it matter that their vitamin A is particularly low if what I would recommend, even with that lab, would be a well-balanced vitamin and mineral supplement? It's not something that we do all the time. I just find it more effective generally to try and focus on the acceptance of a well-balanced product. But I do know in my own case, when I was pregnant and I asked to have my vitamin D screened, I think I paid $75 or $100 for it, and I was a little taken aback by that. So in my own experience, I got to pay for that one out of pocket. We have so many requests for Pediatric. I feel physicians often request it without real cause. Oh, I know that is so hard. For me, my thanks, Cheryl. For me, my line is Pediatric makes a terrible vitamin. If all you need is vitamins and minerals, you need a liter of Pediatric to have it be a pretty effective vitamin. So that would be my last choice. And I say that to families a lot. There are a lot of families who will come in and say, oh yeah, he takes one Pediatric every other day. I'm like, no, please, and he doesn't really like it. Try and focus on something better. I I'd be curious, Jean, it looks like you asked the question about a liquid nutritional supplement. I would love to hear if you guys have products that you like, that you recommend to families. I have a few and they haven't changed over the past several years. So if you've seen me do a presentation before, I've got a powder, I've got some liquids. That's all my team all knows what Sarah's favorites are, and I'd be very happy to share those with you. But NutriStart vitamin powder is one that I absolutely love. It's very well balanced, it's affordable, and it can be mixed into beverages. It can be mixed into food for kids that, I don't know if you guys are seeing as many kids with tube feeding as we used to when I worked there, but it can go through a tube really easily. And Ilan, I feel the same about instant breakfast as I do Pediasure, essentially. It's okay, but I feel like we can, if food is an option and if a vitamin and mineral is an option, I would try those first. And if we're not able to get there with those products, that's when I would be looking at a liquid.
I would like to add a little snippet to that from my perspective as a feeding therapist, often the oral motor therapist, what happens with kids that get put on Pediasure without a big reason for it, they kind of get stuck there, and then their parents will come back to us and say, but they don't eat solid food. And I look at their skills, and their skills are perfect, and there's nothing wrong with the child's eating ability. And I say to Sarah, do we need this Pediasure? Oftentimes. And then lo and behold, when we reduce the Pediasure, they start swallowing the food. So when I see kiddos, yeah, exactly, Joan. When I see kiddos who are participating in the mealtime, chewing up and spitting out their food, sometimes swallowing it, they might swallow a teaspoon or a tablespoon. That's the first thing that we recommend, and oftentimes, and sometimes we see those kids in clinic, and it could have been a pretty easy fix. They didn't need our full team for that.
I realize we're at the 4 o'clock hour, and I want to honor your time as well as everyone else, and we could go on forever. And I will follow up with Sarah, because I had this little lightning storm of like, oh, could we just set up a telehealth consult with some tricky cases? I do wish we had more time, and I will look at ways that we can, let's see, Sarah did say, I might get in trouble for saying this. That's what I love about Sarah. But we get to work with a lot of doctors, residents, and fellows. They all say they wish they had more nutrition education. So don't discount your knowledge and the power you can have in discussing nutrition with doctors. Hallelujah. Well said. Yes.
And they would say the same thing about breastfeeding. So if any of you are also IBCLCs, don't discount your lactation knowledge.
There are many. So thank you for that, Julia. And I think the takeaways that I was hearing is just so reassuring, because there was a lot of scaffolding going on with brain science and parenting styles and motivational interviewing or participant-centered services. The whole part of listening and understanding and trust and building on small successes and ultimately helping people grow. That is exactly where WIC is coming from. And it's just so great to hear of a transdisciplinary team. I love that. Being able to address these issues. So next time, more time, and we'll do some case studies and really dive in. So this is just the beginning of a great relationship. So thank you so much, Julia and Darren and Sarah. Sarah, I'll follow up. Julia, maybe I can get some of the resources from you, and some of your, Sarah, some of your, the one that you mentioned, I think it was NutriStart. I might have gotten that wrong, but
yeah, I've got a PDF with pictures
excellent.
and all that of my favorite vitamins and minerals.
So if we could share that out, that would be great. Yeah. And Julia, thank you for promoting Feeding Matters. I've been following that group for a long time, and it's really great stuff. So we will look at that both in terms of how WIC is asking questions and screening for feeding, but also as a resource for our WIC staff. So Cool. Thank you so much. And I look forward to your other colleague sharing at the August meeting. So it's just a continuation of the great CDRC OHSU team. And thank you so much. And thanks everyone for joining. I'll send out the certificate and we will be posting this recording online with our resources. So great. Thank you.
Thank you, Cheryl. Thanks,
All right.
everyone.
Thank you.
Bye-bye.
Bye.